So welcome to the Lifebulb seminar series focused on organ transplantation. Today, we're going to talk about game-changing innovation in the field of transplant. And my name is Karin Heemberger. I'm the president of Lifebulb. I'm here in the role of a transplant recipient, but also as someone who's trained as a physician and scientist for many, many years. I'm really privileged to be here today together with Professor Ken Newell and from Emory. When it comes to approaches to preserve the organ and truly get an organ into a person, during that transport, there have also been developments. Can you share a few things that have happened in the past few years?
I think that's one of the areas of greatest innovation, and it seemed to have sprung out of nowhere. But when we go through our memories, we find it's not true. So you're referring to the old way of preserving an organ which is still probably the most commonly used way, is to flush it with a special preservative solution that's very cold and to store the organ on ice. So somebody once said, it's no surprise that things last longer in the refrigerator than they do, on the counter. That works, but it gives us a limited window of time to transplant the organs. And there's still organ injury going on the longer it sits outside a human. Innovators in transplant back, in the 70s and 80s, Dr. Belzer, world-renowned transplant surgeon at the University of Wisconsin, his dream was to be able to put organs on a machine that would pump them and keep them more like they would be in the human. And that field, again, took a long time to evolve. And it went through fits and starts. But in just the last little bit, people have found that, especially in terms of livers, lungs, even hearts, you can take organs that in the past we couldn't transplant, put them on the pump, and the pump helps not only preserve them, but may help them regenerate and help them improve. And you can also do testing on the organs to try to say which of these organs are likely to do well and which are just maybe not good organs to transplant. So it provides safety by letting you assess the organ, or as somebody said, it's a trial drive. Will this work? It allows you to use organs you couldn't use. And in the future, you may actually be able to manipulate the organ, improve its chemical environment, if you will, or physiologic environment to make it better. I think that is really exciting, both in terms of increasing the supply of organs, but also the safety and quality of the organs we're transplanting.
So as I understand it, it would both be applicable to organs that are coming from a donor to a recipient, but in the latter case, could it be that a person could get his or her own organ amplified in a system and put back in again?
No one has really mentioned that. I don't know if it's that good yet. That if I'm still alive talking about this in 20 years and that works, I'll be sure to give you credit.
That's interesting because you were talking about regeneration. So if you have a kidney that is about to go into stage 4, 3, maybe 4, you're not yet a candidate for dialysis. But you take it out in an easy process, regenerate, put it back in again.
That is still over the horizon. And from my vantage point, I was talking more about taking organs that have been injured, perhaps in the life of the donor, or perhaps in the storage process prior to transplant, and to make them better. To make them go from maybe not safe to use to make them safe to use. So that's kind of, I think, where we're going right now. But that's been truly transformative. And I think in the future, organs will all be handled in that way.
Yeah, that's right. And that's also something where you have a precedent with liver, right? So liver is already kind of doing that. So with kidney,
and lung is doing it, and heart's been doing it.
And heart. Yeah. So there's no reason why kidneys should not get the same treatment.
Kidneys are currently pumped, but the pumping that has revolutionized lung, liver, and heart is called normothermic, meaning you don't cool the organ anymore. The organ stays at a human temperature, so to speak, at a normal temperature. Kidneys are currently, when they're pumped, it's almost all cold solution going through them. That's where we have the most experience. But I think over the next few years, that'll really become standardized what works. And it may be slightly different from organ to organ, but I think as a whole, what works for one organ will eventually work for most organs.
In kidneys, there's often this kind of lag period, so-called quiet kidney or silent kidney, for up to a week or so, even for some patients before it kicks in. I mean, personally, my first kidney transplant took 3 days before it kicked in. It was a very difficult period when you didn't know if it was going to kick in or not. Do you think the perfusion would have any kind of impact on that, or is that just the settling in the new environment?
No. So that is called, in the transplant surgeon parlance, delayed graft function, meaning the graft is not functioning immediately. And it may go for 24 hours, it may go for weeks, or in some cases, even a month or more. The one thing that's very clear is it seems that in all the well-done studies, the one common thing is with kidneys, those that are pumped have a lower risk of delayed graft function, meaning they either work sooner or they recover more rapidly, or they don't have any delayed graft function. They just work immediately. But that's with a subset of kidneys. That's only with those kidneys that you're most worried about, or that it may take the longest to put in, because the risk of a kidney starting to function slowly, it increases the longer the kidney's kept out of the body. That's why with living donors, where the kidneys may be out of the human body for an hour and a half, the risk is very, very low. If you take a kidney that goes into somebody or comes from the state of Washington and goes to Atlanta, and it takes 30 hours to put into somebody, the risk of slow function is going to be higher. So I think the real question is to find out, do all organs benefit from being pumped, or is it just some, and which ones? And then to try to refine what is the best way to pump those organs. I think that it's already revolutionized liver transplant, and I think it will revolutionize kidney transplant as well.
That's really interesting. So finally, I just wanted to get your view on what is the importance of matching. We hear all the time now that if you have someone who wants to donate a kidney to you, you should take them up on it, even if they don't have the same blood type, same tissue type, because there are systems in place that you may be able to get a match in some other way, vouchers and so on. What is the truth to that?
So matching is important, but again, it depends on what you're trying to measure. So if you look at, and for living donors, for instance, matching is important perhaps in long term, or a better way to say it is avoiding certain mismatches. But the most important thing is getting a kidney from a living donor. If you say, what's the one thing that increases longevity, quality of life, function of the organ, it's getting a kidney from a living donor. The second most important thing is getting a kidney as early as you can in your dialysis. So if you have to have dialysis, if that can be 2 months as opposed to 2 years, that's a big difference in how that kidney functions. We then used to say, some people would say, well, I've heard matching's important. If you take the very best matched kidneys from deceased organ donors, they still don't function as well as less well-matched kidneys from living donors. So that's a powerful thing.
That's very powerful.
Start getting into, I want my kidney not to go for 8 years, but I want to go to 20 years. People are now starting to talk about this thing called eplet mismatching. And it's certain targets that your body's immune system will preferentially see and will prime a rejection response. And by avoiding these certain mismatches, they found that kidneys may go much, much longer than they currently do. So we've gone away from the concept of matching to saying we want to avoid really dangerous mismatches. And so I know there are some programs like the National Kidney Registry. They have a program that, if I'm not mistaken, is called Kidney for Life, where they're trying to minimize this mismatching. and they believe these kidneys, will go much, much longer. And so far, the data seem to suggest that's true. You can apply that sometimes in a very carefully controlled living donor situation where you have time, right? You have a little more time to work. It's very hard to do that right now in the setting of deceased organ donation.
Yeah, it happens so immediately. I mean, when you have an offer and it's somewhat a match, you're going to take that kidney.
And the way kidneys are allocated is a whole separate thing, but there's no allocation right now that preferentially prioritizes this mismatching, even if the testing were available in real time.
Yeah.
But the good news is people are studying this, and we will find out over the next several years, how important this is. And if it's important, I think the field will figure out ways to implement it.
That's great. And I do think, you made a strong statement that getting a kidney earlier is better. Getting a living donor kidney is better. We've heard a lot lately about xeno. What is your sense of when that could come onto the market?
I've heard about and been familiar with a number of people working in the xenotransplant field. And somebody once said it's just around the corner and always will be. And that was said for years. But I think over the last maybe 5 to 7 years, there's been some real transformation in the ability to knock out some of the genes that make the proteins that the immune system targets that cause rejection. And the response to these xeno organs or organs from animals such as a pig is much more robust or much stronger than the response to a human organ. So one approach to this is to knock out some of those genes that, if you will, make the pig, or even, and when I say knock out, remove them, genetically remove them, or even put new genes that are more human back into the pig cells to control the human immune response. So I think we've gone from somewhere where most people thought it's pie in the sky to the point where, as you know, there have already been some very limited experiences. And I think we may be on the cusp of some clinical trials to actually do this, because we can only learn so much from doing one-off transplants. And at some point, we need a little more bigger experience.
And that's, again, a risk. But again, I think the comparison with xeno is not against allo. The comparison with xeno is really life on dialysis. So the patients who are now being considered for xeno are those who have no real opportunity to get an allo transplant or get a transplant from a relative or from the UNOS list. And there is a path for clinical trials to address that portion of the population.
Yeah, I think there are many ethical considerations in this. And I think that the people really invest in xenotransplant have thought through that very carefully. They might not all agree on an approach, but I think there are a number of approaches where this could be done safely.
Yep. And then, of course, taking care of that kidney when you've received it, taking the drugs, staying compliant, doing the screenings. And I think enjoying the freedom from dialysis or from end-stage disease is probably going to impact the kidney as well. Those are some of the valuable pieces of advice I think you can get from those who have had kidney transplants for a longer period of time.
Well, one thing I tell patients when I see them, because part of the education system is to tell people how long kidneys are expected to last.
Yeah.
There is data from huge numbers of transplants, but I think the truth of the matter is we don't know, because so many kidneys are lost because the drugs have toxicities and people don't take them, or they don't control things like blood pressure. The patients I know who have done really well, including one gentleman whose kidney lasted 50 years, are, for the most part, very, very compulsive about their health. Not to the point that it ruins their life, but they don't sit in their house, waiting 12 hours on the couch between taking medicines. They're living their life, but they know the things that matter. And I think we have no idea if people, take good care of their bodies and take the medicines that are necessary to prevent rejection, how long kidneys could last. It might be much longer than we think.
Yeah. Yeah. I mean, averages are always hard, right? Looking at either the average or the median. And it's still depended on where the field was as well when that average started. And each person is an individual. It is very, very hard in this space to look at that. As a patient, I never look at averages for what was done, 20 years ago, because I do think that even the environment right now is different, and what we know about mental health and what we know about nutrition and know about how to take care of your metabolism it's just very different. So we do need to follow the advice of our physicians. I think that's truly important, and kind of have a good sense of judgment in not risking things that could truly ruin the prospect for future health. This is great. I really, really appreciate the time. And I think we learned a lot. What are the game-changing innovations that we can see in the near future? And I appreciate that. And as someone who's been in the field for so long, I thank you for sharing your experience as well as your hopes for the future. Thank you.
Thank you for letting me share some ideas.
And I also want to thank ITB Med for sponsoring this seminar series. And I welcome, of course, anyone who wants to contact us afterwards to reach out. Thank you very much.